Welcome to week 9. Can you guys believe it? Week 9 of ST310. So tonight we have an overview of chapter 13. We're going to be looking at patient monitoring, local and regional anesthesia. But do not forget your mini session. Let me go ahead and put it in the chat. We have some mini session questions this evening, but if you hadn't seen it already, that's okay. You'll still be able to kind of go with the flow. We have our Kahoot game, time permitting. We have some questions from the mini session, like I mentioned, and then we have our breakdown of our recall, application, and analysis questions. And um, let's get into our quote of the week. I had to remember what class this was because you guys should hopefully see some Moodle messages that I sent you guys for tomorrow. Okay. So our quote of the week. The only way to do great work is to love what you do. And that's by Steve Jobs. Now, as STs, we are so important when it comes to being a part of the surgical team. The work that we do is so vital in just making sure that the surgeries go very smooth and patients receive the best possible care. Now, the quote itself is a reminder that in order to truly excel in your role, you have to have a passion for it. Every time you scrub in, pass an instrument, or just help maintain a sterile field, you are contributing to the patient's well being. If you approach each task with dedication and care, you'll find greater fulfillment in your work. Now, when you love what you do, you will notice that every challenge becomes a chance to kind of grow and learn. And then your efforts make a real difference in the lives of others. Okay, so that is our quote of the week. And let's start off with a little mini session question. I have two mini session questions right off the bat. So, question number 1. Which statement best explains the difference between hemostatics and systemic coagulants? Is that A, systemic coagulants act throughout the body to promote clot formation, while hemostatics control bleeding directly at the surgical site? Or hemostatics must be given orally to stop bleeding, while systemic coagulants are always applied topically to the incision. Is it A or is it B? Yes, it is A. Hemostatics work locally at the wound or the surgical site to stop bleeding. Systemic coagulants act throughout the body to improve clotting ability. Okay, here's the next one. What statement best describes the clinical purpose of warfarin, also known as Coumadin? Because you may see it either way asked on a question. Warfarin is used to stop bleeding quickly during surgery by strengthening clot formation. Or B, warfarin is used for long-term prevention of blood clots by reducing vitamin K dependent clotting factors. A or B? What do you think? That is correct. I saw some answers already. It is B. Warfarin, Coumadin, is a long-term anticoagulant. It's not an immediate surgical medication. It reduces the vitamin K dependent clotting factors, and that's what really slows down the clotting process. All right, good job. Now, questions to kind of think about as we're going through the material. I want you to think about how each physiological vital sign monitor is in surgery. I want you to think about which types of monitoring are considered invasive and what are the 4 major types of anesthesia. They are going to be answered in tonight's live session. So, What are our learning objectives? Well, for 13.1, we're going to start off by defining terms and abbreviations. We're going to explain the types of patient monitoring devices and discuss monitored anesthesia care, also known as MAC, at its levels of sedation, because there are many concepts that I've seen on MAC specifically. Okay, now we get into the beginning. We look at direct observation, visual assessment of the patient's condition, and that is by everyone in the room. It's often the first line of patient monitoring. Like, we're just watching the patient come in the room. We're looking at, are they alert and oriented times? However many, right? We are checking their gait, how they're walking, how we're transfer them over from the gurney, the wheelchair. Do they walk in to the operating room bed? This helps us as a surgical team identify immediate changes in the patient's condition, breathing patterns, skin color, movement. Direct observation is so important for monitoring just basic vital signs like their breathing, their circulation, especially during anesthesia induction and recovery. Now, while it's the initial method of monitoring, there are more advanced or invasive techniques that may be needed for specific procedures or patient care complexity, depending on what the patient's got going on. Now, make sure you look at 13.1 for a summary of the most common psychological functions monitored in the surgical patient. So here you have the device, what it measures, and why it matters. Okay, so this is pretty much what we're going to be talking about this evening. Okay, so we get auscultation, where we're just listening to the body sounds, the heart, the lungs, and we're checking the patient's condition. We have blood pressure. This is the force of the blood pushing against the walls of the blood vessels. It's so important to monitor during surgery because we want to make sure the patient's circulation is moving properly. Now, this one you may not have heard about often, the capnometer. Okay, here it measures the carbon dioxide that the patient exhales. This helps assess their breathing and respiratory status. Now, in the operating room, anesthesia is used regularly, and these tools are going to be really important to help monitor what's going on with the patient's vital signs. We have our electrocardiography, also known as our ECG. This is a test that just records the electrical activity of the heart to monitor heart rate and rhythm. Our epidural, a lot of times our patients will get this, just an anesthesia injected into the space around the dura mater, which is that protective covering of the spinal cord, and it's really just to numb the area. And exsanguination. If you're going into a lot of orthopedic procedures, we do this to make the area bloodyless. Believe it or not, ortho, depending on the case, when we're doing, let's say, ACLs and different procedures, it's one of our least bloody cases. It's more water everywhere and fluids, but it's often done to really improve visibility and control bleeding. But we're not done. We have a couple more. Intrathecally. This refers to anesthesia given directly into the spinal canal, often for spinal anesthesia. We have local anesthesia. This is going to be some of the first things that we're handing our surgeons, hint, hint, during most of your procedures. So a lot of times you're giving them light handles, sponges. We do our timeout, depending on whether it's done before draping or before skin incision. And then you're handing them that local. That's usually how it goes, local knife, okay? Now, this is going to be applied directly to a specific area to block the pain. Okay. Now, we're going to talk a lot about MAC, a type of anesthesia that includes sedation, pain relief during a procedure with continuous monitoring of a patient's vital signs. We check the pulse ox. We actually place these on the patient's finger in the operating room so that we can measure the oxygen level in the blood and the heart rate. Um, this is literally one of the first things that happens. The patient comes in, they're put onto the operating room table, warm blankets given, and then they start getting hooked up once, we get them usually intubated. Sometimes it's simultaneously. And our regional anesthesia. Anesthesia injected near a nerve plexus to block pain in a larger area. A lot of shoulder cases, this will happen before we start our case. So they'll get that to kind of prolong the anesthetic effect after the case is done. Okay. It affects both sensory and motor function. So a lot of times it's going to be numb. They're not going to have much functionality of that limb or other part. Sometimes you may have to get an arterial line. This can happen pre-op or interoperatively. These are going to be for ABGs or arterial blood gases, or like let's say they're trying to get a routine blood pressure measurement. It's just not working. It's unreliable. So they're going to pull this out a lot of times interoperatively. The line is typically inserted into, as you guys can see in the image, the radial artery and connected to a transducer. And then that's continuously recording like arterial pressure. So it is a lot more accurate. It allows for like real time monitoring of blood pressure. And again, it is more accurate blood gas analysis than just having the blood pressure cuff. We also have the central venous pressure, CVP lines. They're used to assess the volume of blood that's actually going back to the heart. It helps in managing fluid balances during surgery. Not every patient gets this, right? But it's very important for monitoring the need of fluid replacement and really preventing fluid overload in some of our patients that is like a concern. Okay. Now, again, these lines are usually placed in the vena cava and are used to measure central venous pressure. We really just want to make sure that their cardiovascular heart and everything's going how it needs to be. The chapter also talks about the Swan-Ganz catheter, okay? Now, also known as the pulmonary artery line. So you may see Swan-Ganz catheter, aka the pulmonary artery line. Now, this is used to measure multiple types of pressure. So it will measure CVP, central venous pressure, PV, pulmonary artery pressure, pulmonary capillary wedge pressure, and cardiac output. It provides really good data during a lot of heart procedures. Um, Maybe there's a lung transplantation or even a liver transplant. So these are going to be the ones where we're going to definitely want those. The catheter's inserted through the heart into the pulmonary artery. And this is offering like real time monitoring of what's going on cardiovascular. And it's really important again because we're just trying to manage fluid status and looking at that cardiac output during those type of procedures. Okay. You also have to know about ATEE. Okay, this is an intraoperative cardiac imaging where now they're assessing function by really just kind of like observing the heart muscles function. They're looking at the heart walls, they're looking at valve function, they're also looking at intravenous fluid volume and the presence of air in the heart. Okay, so that's really important. Now, this probe, believe it or not, is inserted into the esophagus. And then high frequency sound waves create kind of like that real time image of the heart. It provides good detail. It's non invasive monitoring. Um, it's particularly good during cardiac procedures. And the technique allows the team to just really closely monitor the heart's condition and make timely adjustments. Now, for 13.2, we have to look at local anesthesia, including applications, common agents used, examples, and safety considerations. We have to discuss regional anesthesia, but more specifically, applications, common agents, and then look at some examples and then types of regional blocks. So, local. The goal of local anesthesia is to just block sensory nerve endings. Okay. Local anesthesia can be injected directly at the surgical site. So this is why this is one of the first things you're handing the surgeon. Literally, one of the first things, if they're going to inject. If they're the type of surgeon that just draws and then cuts, then you won't. But most likely, it'll be draw, inject, knife. Okay, sponges, Bovie pencil, etc. Now, when local anesthesia is being used without an anesthesia provider, because sometimes that happens, you may have an RN, they have to be assigned because they have to monitor the patient's vitals throughout the procedure. A lot of pain cases, this could be definitely where anesthesia is not there, but there's always going to be a nurse. So it'll be like you, the surgeon, usually a neurosurgeon, but it could be a pain doctor too, and then a nurse is going to be in there with you. Now, only physically healthy and psychologically stable patients are suitable candidates for local anesthesia without continuous monitoring by an anesthesia care provider. So, a lot of your pain patients have to meet that criteria to not have an anesthesia provider there. Not saying they can't get it, it's just saying that an anesthesia provider has to be there too. We look at regional up to the top here. Now, now we're talking about that nerve plexus. Okay. The same local anesthetic agents can be used in both local and regional. So kind of keep that in mind. It's just about where it's going in the body. That's the kind of key things. In both cases, the same vital signs, heart rate, blood pressure, oxygen saturation are monitored closely. We talk about sedatives. Sedatives may be administered intravenously, and that's kind of one of the first things the patient may get to kind of help relax them or help them to remain comfortable during a procedure like a colonoscopy or an EGD. A lot of times, those patients aren't necessarily induced, but more relaxed, if that makes sense. The patient remains awake during the procedure in both local and regional anesthesia. Now, they're not going to feel the pain in the anesthetized area, so kind of keep that in mind. Now, the similarities themselves emphasize really how both anesthesia types are designed to kind of manage pain effectively while keeping the patient alert and their vital signs stable. Now, we get to the local agents. Okay, make sure you're going back and you're taking a look at these. For example, we do use cocaine in the operating room a lot of times in ENT. Topical cocaine, injectable provocaine is the name, or novocaine. Okay. We have benzocaine, which is topical. We have tetracaine, which is local anesthetic. It's long acting. These are your amino esters. That's the very first ones you guys see. Now, your amino amides, these are the ones you're going to be using almost all the time. Lidocaine, aka xylocaine. Make sure you know both names because some facilities may have xylocaine, some facilities may have lidocaine. It's the same. Bubuvacaine is another one. A lot of facilities will have bubuvacaine or marcaine. It's the same ad. Sensorcaine is another name, but you'll usually see bubuvacaine and marcaine. You have naparine or ropivacaine, and then you also have one that's less commonly used called mepivacaine or carbocaine. Okay. Again, the ones you're going to see a lot in the aminamides are lidocaine, xylocaine, bubuvacaine, and marcaine. Those are going to be the ones you see a lot. Now, the duration of action of local anesthetics is due to the difference in their plasma protein and how it binds and the capacity and their individual lipid binding affinity. Now, local anesthetics without epinephrine may have a blue band on the label. Now, sometimes, especially in ortho, you may get lidocaine with epi or lidocaine plain. Depends on the procedure and surgeon's preference. Okay. We get the use of epinephrine. Now, so remember, this is that drug that you have to be extremely careful of because 1 to 100,000 is a different strength than 1 to 100,000 or 1 to 200,000. Okay. Epinephrine with local anesthetics. Now, when epinephrine is combined with local anesthetics like concentrations of 1 to 100,000 or 1 to 200,000, it causes local vasoconstriction. But what does that mean, right? It means that the blood vessels will constrict in the area where the anesthetic is injected. It kind of allows the medication to kind of get into the system more because it slows it down. Okay, so it's not able to kind of go really fast, it's slower. Um, and it gives the absorption more time to get into the bloodstream. This keeps the local anesthetic in the surgical site for longer time. That increases the duration of its effects. But there's a cautionary tale with epinephrine. Because remember, it can come into 1 in 100,000, which is 100 to 200 times more potent than the concentrations used in local anesthetic mixtures. And that's why we really stress epi. If epinephrine in its high concentration is injected instead of applied locally, it can cause severe complications, even death. Now, epinephrine, when used in local anesthetics, is in very low amounts and is designed for specific routes of administration, typically injected in very small doses. Usually, you're handing your surgeon 10 cc's, they may use 2 or 4 at one point, you're getting 6 back. You keep it because they may use it more later in the case. Okay. Now, misuse of high concentrations can again lead to those dangerous outcomes. And that's why you're constantly hearing me stress we're going to trust, we're going to verify, we're going to label, right? Before we do anything. Now, we look at the common uses and key points about administering regional anesthesia for like your lower abdominal, your perineum, and your lower extremity procedures. So, skin is prepped with anesthetic agent before injection. A lot of times we may even have to help our anesthesiologist, so just kind of keep that in mind. So like anesthesia may say, "Hey Quincy, I need you really quick." You're doing your thing. You're like getting your groove on. You're setting up your case, and you're like, "Okay." And so you're really just there to kind of they'll give you their like sterile supplies, and then you're just kind of handing it to them. Um, but local anesthesia is injected through the skin, usually quicker than any other forms like epidurals. Common agents, tetracaine, bupivacaine, ropivacaine. Again, we're talking about lower abdominal, we're talking about perineum, we're talking about lower extremities. It's used in procedures like transurethral resections of the prostate as well, bladder tumor removals, and lower extremity vascular surgeries. When we look at epidural anesthesia, now, the anesthetic agent is injected into the space surrounding the dura mater. Okay, chapter or figure 1311 has a good image. There's also common applications, widely used for pain relief during labor and delivery, and provides anesthesia for cesarean sections. Bupivacaine is a common choice for obstetric epidural anesthesia, with a concentration of 0.25% and 5% being the one that's usually used. But there's also what's called a walking epidural. This is a combination of 0.125% bupivacaine and a very low dose of fentanyl that provides that kind of like walking epidural, which kind of gives the patient some mobility. Okay. Now, there are advantages to epidural. You have a reduced risk of hypotension, lower incidence of post-dural puncture and like headaches. And then there's flexibility in administration. So, epidural anesthesia can be administered at levels above L3 to L4, and that's where that flexibility for various procedures kind of comes in. So, it doesn't have to be just for a C section or just for, one thing or another. Keep in mind that epidural anesthesia is preferred over spinal anesthesia when the surgical procedure duration kind of is variable or is extended, or when prolonged postoperative anesthesia is needed. Now, keep in mind that epidural anesthesia does offer more versatile control options, especially again for those who are going to be in OBGYN and you're in labor and delivery. Yes, we can assist in labor and delivery um, with the ability to kind of adjust anesthetic doses based on the procedural needs. A lot of times when we are assisting in labor delivery, it's kind of maybe a complicated case, or we are prepping for a potential C-section with multiples. So the patient will actually deliver sometimes in the operating room, and then we have our stuff set up just in case when it comes to multiples. So I will be sharing this video for those who are watching, and those for you who are here to kind of like just explains how it goes. We have the caudal block. Okay, this is a type of epidural block where the anesthetic is injected into the epidural space, and it's through the sacral canal, which is located at the base of the spine. So, in the past, caudal blocks were used for vaginal childbirth, but this practice, believe it or not, is rare, with the lumbar epidural kind of being the preferred method for labor and delivery. So now the caudal blocks are sometimes used in
Right
children.
there.
Go ahead.
Hold
So in the past, caudal blocks were used for vaginal birth, like I mentioned, but sometimes it's used in children for lower extremity surgeries, often in combination with general anesthesia and for pain management. The type of block can be used for like postoperative pain, a lot of our spinal patients, particularly to help with the lower body. So there was a shift in practice. Caudal anesthesia was very common. But again, lumbar epidurals kind of like swooped in and took over. Okay. So let's take a look at how they were done.
To find the sacral hiatus, first identify the two posterior spines on the sacrum. The sacral cornua lie at the apex of an equilateral triangle. Feel for the sacral hiatus in the space between the cornua. A needle inserted at this point and angled upward a short distance will pass through the ligament and lie within the end of the canal.
So not too crazy, but you can kind of see how it's done. Okay. Now, the question I got, whose idea was that? Now, a lot of it's going to be really anesthesia. Wasn't like, oh, okay, never mind. The spine is better. Okay. So, um, as technology or practices, right? It's kind of like in the beginning how we used barbers for surgeons, and then we went to school and we learned better techniques. So it's kind of the same idea, but you're already kind of thinking on the right path. Now we have what's called extremity blocks, also called regional nerve blocks, that sometimes we'll do. Distal arms, legs, procedures for the hands, fingers, feet, toes, or even sometimes smaller localized surgeries, minor surgical procedures on extremities where anesthesia needs to be kind of local to the affected area. Um, Sometimes we do caudal, like these on like where we're doing toenails and different stuff like that. Now, it's preferred in some cases. Now, while spinals or epidural anesthesia are typically preferred for like lower extremity surgeries, where we're talking about the hips or thighs, extremity blocks are going to be better. And I want you guys to think about it's going to be for those hands, feet, smaller extremities, okay, where you're not necessarily needing the whole arm anesthetized, okay? More precise localization is what I'm trying to say of the nerves. Um, so it's able to kind of penetrate the nerve sheath, and you don't have to necessarily worry about damage to nearby blood vessels that can lead to bruising. Okay. We have our brachial plexus block or our axillary block. Now we're talking about our hands, our forearms, our elbow. Um, Basically your upper extremity surgeries. Okay. This is the most common method for administering a brachial plexus block. Now, it's going to go into the armpit and it's going to target the brachial plexus. Okay. But this is the thing with this time required to take effect is a big thing. Sometimes 15 to 30 minutes for the anesthetic to take place. So a lot of times these patients will get the block in the holding area, usually about 15-20 minutes before they come to us. So that way, when we cut, the anesthetics or the anesthesia has had time to kind of do its thing. Okay. But that also means that you have timing is so important. That's the only thing. We have our intravenous regional or our IVRA. This is known as your bear block. I have seen questions or concepts on the bear block. This is a regional anesthesia technique used for upper or lower extremity surgeries. Now, the procedure itself involves the use of a tourniquet, and that's to isolate the limb. And then lidocaine, which is the most common anesthetic agent, is injected into the venous circulation, and that's what achieves the kind of numb extremity. Keep in mind, the most common anesthetic is lidocaine, lidocaine. But bupivacaine is contraindicated because it has toxicity, is more closely associated with like intramuscular administration that can lead to cardiotoxicity and central nervous system toxicity. So that's something that we do not want to give. Okay. Now, the chapter also talks about a double tourniquet system is commonly used where the tourniquet is placed closer to the torso, and that's to prevent the spread of the anesthetic agent, and then the other is placed near the surgical site. So it's like a double tap kind of thing. And yes, the last thing we're going to talk about is an eye block. So we have the retrobulbar block. This is a type of regional anesthesia used for ocular surgeries, particularly in the eye, where the anesthetic is injected behind the eye in the muscle cone. Now, you see a couple needles going into the eye, and I'm going to explain that. Okay. But before that, bupivacaine and lidocaine are typically used in the injection. It's often combined, um, and it helps just kind of spread the anesthetic with hydrogenase, and it's effective in the tissue. Okay. Now, the injection may be performed by an ophthalmologist or your anesthesia care provider, just kind of depends. I'm used to the surgeon doing it, but the chapter says anesthesia care provider can do it as well. Now, the anesthetic is delivered into the space into the optic nerve. So we have the retrobulbar block. This is rarely used because of the risk associated with the injection near the optic nerve. So you're looking at these two needles and you're kind of seeing how close, how where it's going in respect. Okay. Other things that could happen was optic nerve injury, retrobular hemorrhaging, where there's just blood coming out, or damage to surrounding structures. As a result, it has been largely replaced by the parabobular bulk block. This is where the anesthetic agent is injected outside of the actual muscle cone and away from the nerve block or away from the nerve. Now, this technique kind of just avoids all of those potential risks of the retrobulbar block. It does require more anesthetic than the retrobulbar block because it has a slower onset. It has more tissue to kind of get through, but it's a safer option. So kind of like keep that in mind. Okay. Now, back to our mini session questions. Here we go. A surgeon needs a quick control of bleeding at the incision site. Which type of medication is appropriate? A systemic coagulant giving intravenously to increase clotting factor, or B, a topical hemostatic agent applied directly where bleeding occurs? Which would be the best, in your humble opinion? Yes, Crystal's like, I'm on it. That is correct. Um, Keep in mind, topical hemostatics are immediately at the wound site. They're ideal for our environment because we can get in there and get it done. Okay. And then our last one. Okay, going back to warfarin. Okay, which option correctly describes how warfarin Coumadin works in the body? A, interferes with the vitamin K, or B, increases the liver production of clotting factors? And it is A, it blocks vitamin K actively, and that reduces clotting factors. All right, now for the fun part. Let's break down some questions that you may see this week into recall, application, and analysis. So, our recall question. Keep in mind, they all have the same answers at the end. Okay, so we have question one. Injection of local anesthetic into a nerve plexus supplying the operative region is referred to as what type of anesthesia? So again, we're kind of thinking about what we just read, what we just kind of went over in tonight's live session. A patient undergoing hand surgery receives anesthetic injected near the brachial plexus to numb the entire upper extremity. What technique is being used? During pre-op, the anesthesia provider decides to block transmission through an entire nerve plexus rather than infiltrate tissue locally. Which type of anesthetic approach does this represent? So now we get our two options: local anesthetic or B, regional block. Which one is it? Correct option is B. Same question asked three different ways. Okay. And our last one. Which brand name corresponds to the local anesthetic drug lidocaine? So we're putting in our mind and we're like, okay, application. During the procedure, the surgeon asks us to confirm the availability of lidocaine. The medication label reads, which brand name indicates the correct drug? You're reviewing a medication cart and notice multiple anesthetic vials. To avoid medication error, which brand name should you associate with lidocaine based on pharmacology principles? Marcaine or xylocaine? Yes, xylocaine is recognized by brand name for lidocaine. This is commonly used amid lots of local anesthetics. Okay. Now, you guys are doing really good. Okay. So I am going to share the Kahoot. Had it up. Hold on, you guys. For you. Copy. For those of you who are watching, you will still get the same one. For those of you who are here, we only have 10 questions. Let me make sure I'm right. 10 questions. If you are not able to join, do not stress. You can kind of type in your answer into the chat. For those of you who are able to join, here is the game pin is 771459. 771459. And if you are not able to join, just let me know. If I can get on. No worries, no worries. Thank you. Okay, so let me. All right, so let's go ahead and start again. For those of you who are not able to join, just go ahead and type the answer into the chat. There we go. Yes, you can put the color. Yes. Okay, so it looks like I did this one kind of fast, okay? So this is one of those where we're kind of like thinking and just going, okay? All right, next question. True or false? Local anesthetics. False is correct. Remember, local is going to be affecting just like that particular area. It is true. Okay, next question. Which statement about retrobulbar blocks is true? Remember retro and retro, okay? Don't get them confused because sometimes they'll throw that at you. So remember that the parabulbar block replaced the retro, okay? Next question. What is the primary purpose of epinephrine when added to local anesthetics? Think about what epinephrine does. That is correct. It causes vasoconstriction. So it's like squeezing it. So it allows that anesthetic, whatever it's mixed with, to stay in the tissue longer. Hint, hint, there's a lot of questions on the parabulbar. That is correct. It is true. Next question. This is not true. It requires general anesthesia. Yes. So MAC is going to be one that's going to be for bigger cases because it's constant monitoring. So this is one of those trickier ones, okay? So 1 to 100,000 to 1 to 200,000. Those are local. Um Wait, this one is concentrated one. That is correct. Hold on. I may have to go back to this one. To 1 to 100,000. Go back to that one. Because you guys may be correct. I think I typed it wrong. Right, yeah. I'm going to go check because 1 to 100,000 is the bigger one. Okay. And number 10. Which type of anesthesia is injected near a nerve plexus to block pain in a larger area? Regional anesthesia. Okay, I'm like going through my notes real quick to go back to that one. All right. So we're at week 9. Okay. And you'll notice that I'll be sending you guys some Moodle. I sent you guys a Moodle message earlier today for ST300. I'll kind of break that down and explain what I'm trying to do to give you guys additional resources because I know that ST300 is very dense. There's a lot of information, and I want y'all to be not only prepared for the final, but as you guys go into Module 4 and into the lab, you're confident, okay, going into that because I completely understand there's a lot of information. Um, so I will kind of break that down tomorrow. My thinking, you should already have, if you haven't check out the podcast um, and the kind of like video to kind of help with ST300. By tomorrow, I'm hoping to have like episode 2 out for you guys. And then that way, by finals, you'll at least have 7 additional kind of like videos, podcasts that you can kind of just listen to help you get ready for really the next chapter of your career, not just your final. Like, to me, you guys have already passed this module. We're just going through the motion. I want y'all ready for module 4, module 5. I want you guys to be confident going into your very first um, job as a certified surgical tech. So, if there's other things that you guys can think of that you want just more information on, maybe I'm thinking about trying to get something for decontamination too, although that's not one of y'all that has had a lot of missed, but I have seen once you guys get past this and you guys get into the clinicals where you're not really able to be in SPD, CPD, depending on the facility, what they call it. That way you guys can at least have it as a reference. So do me a favor, think of other things that you guys want information on that I can kind of try to break down. We were introduced to like Notebook LM, and so I was like, oh, this is cool. So I'm trying to kind of like utilize it. You guys are my guinea pigs, so thank you. But that way, you guys will have additional resources to use beyond Module 3. Okay. Now, for those of you who are watching the playback, why do you think the use of retrobulbar blocks has declined despite their effectiveness? We kind of talked about that tonight. How might the misuse of high concentration epinephrine, 1 to 100,000 or 1 to 1,000, impact patient safety? So that question is false. So, Miss Quincy, I think you asked. Yes, you were correct. It is false. Okay. But I'm going to break it down into the announcement so that those who aren't here won't understand why too, because that concept does come up often. And what are the advantages and potential drawbacks of using regional anesthesia instead of general anesthesia for certain procedures? You guys, we covered a lot tonight, okay? Make sure you guys are going back into the book, looking up the chapter, reaching out if you have questions on either chapters, the mini session or the live session that we had this evening. We're coming down to the end. So, with that, I want you guys to get a good night's rest. And I look forward to seeing everyone who can attend tomorrow's live session. We're going to be covering a lot for ST300. With that, good night, everybody.